now recording. Thanks, everyone. So again, if you're joining us by computer, again, thank you, Amanda. You have the video on. We can see you. Hello. And anyone else who's joining by computer, feel free to jump on video too. You can use the mute function in the bottom left, the stop video function also in the bottom left of the screen. Additionally, if you're on the phone, you can unmute yourself with *6 and raise your hand with *9. So we know if you have a question, any comments or concerns. We try to keep it relatively loose here. If you have anything that you want to say, feel free to type into the chat or use one of the functions I mentioned before, even if it's during the presentation or case presentation. We're going to flip things around a little bit as we've been doing more recently. Start with the case presentation and then get into the didactic on energy balance. So with that said, we can go ahead and get started. I'm going to share the screen and bring up the case presentation for today. All right. So our case presentation for energy balance is a 43-year-old female. She was diagnosed 3 months prior to her visit with us in Survivorship Clinic, and she was diagnosed with a stage 1A right-sided breast cancer. She did not have to receive any chemotherapy, but for her surgery, she did elect to have a bilateral mastectomy and deep flap reconstruction on December 10th, 2018. And she received anastrozole for endocrine therapy and started that on December 28th, 2018. We're going to call her Mrs. V today. So if you hear us referring to Mrs. V, this is who it is. She did have a significant past medical history for ovarian cancer, for which she had a total abdominal hysterectomy and bilateral salpingo oophorectomy, so her ovaries removed, in Russia, where she was originally from and treated for the ovarian cancer, along with 6 cycles of chemotherapy. Unfortunately, we did not have any records on that. We chose this because it highlights a multidisciplinary review of weight management related concerns. And the challenges in this case were the treatment related side effects she'd been having from the AI therapy, the exemestane, the body image concerns she presented with, some fatigue, and sexual dysfunction. What we wish we knew for the case, not as significant specifically for her breast cancer, but again, it would have been helpful to know the prior treatment she had while in Russia. She did not complete an intake form, unfortunately for us, so we didn't have her 2 primary concerns coming in. But her pre-distress thermometer showed that she was a 5, and her post-visit distress reduced down to a 4, and she noted that the entire visit was helpful. So Mrs. V lived at home with her spouse and 15-year-old son. She was working full-time managing finances. She did not smoke. She drank 1 to 2 alcoholic beverages 2 to 4 times a month. She did not use any recreational drugs. We weren't sure how much exercise she was getting because no intake was filled out, but her pre-diagnosis weight was 225, post-treatment weight was 235 pounds, and current weight at the time was 233 pounds. Again, we didn't have an intake, so we couldn't get fruits and vegetables or vitamin supplements and herbs that she might have been taking. She had a number of other comorbidities. Again, the ovarian cancer. She had AI-associated arthralgias. She also had ankylosing spondylitis. She had preeclampsia, high cholesterol, high blood pressure, psoriasis, reflux, and sleep apnea. And her family history, for cancer-related family history, was significant for esophageal cancer in her maternal grandfather. So I'm going to go ahead and stop the share and come back to us here. So we're going to share a little bit about our visit with Mrs. V, but I want to stop and I'm going to unmute everyone and let me know or let us know if you have any questions or comments about her case so far. All right, doesn't sound like we have any specific questions or discussion topics right now, so we'll keep going.
Are you called in more?
Sorry about that feedback. All right. So when I had started with Mrs. V, she had a number of concerns specifically related to the treatment she was receiving, the anastrozole, her endocrine therapy for breast cancer prevention. She had some night sweats to go along with hot flashes. And so one of the things I think about from a nutrition-related standpoint is how this could be affecting her night sweats or hot flashes. Thinking about, in particular, with certain foods that could cause it, like caffeine, spicy foods, hot beverages, alcohol. So these were all things I counseled her on as potential triggers, and ended up recommending as well Remifemin, which is a natural supplement, black cohosh. And at her follow-up visit with me over at the breast center, she reported improvement. She was also having reflux, so we talked about irritating foods. Again, things like caffeine, alcohol, and spicy foods, high fatty foods or sugary foods. And I recommended Pepsid. She ended up taking pantoprazole, and she came back reporting improvement at her follow-up as well. She had some nausea that she was waking up with in the mornings, and she noted that it improved with food. So I advised that she speak a little bit more to Maura about that at the visit, and to focus on making sure she was getting an appropriate breakfast in the morning as well as hydrating well. And she had some joint stiffness in her hips since taking the exemestane. So exercise was something that could be beneficial for her. And I discussed with her talking about that with Scott at the visit, working on stretching and exercises to help improve some of her strength and mobility. She had a lot of emotional fatigue as well. Returning to her normal routine was a challenge for her. And so, I made sure I was utilizing empathic listening during the visit. I helped to normalize that experience, that this is something many survivors struggle with. And she ultimately sought mental health counseling. And then she struggled with her body image as well, with concern about, feeling like a woman. And, she had the bilateral mastectomies, and though she had declined referral to our sexuality and sexual health clinic here at Yale, I discussed with her that this is, again, a normal experience, helped to normalize some of those emotions, and talk to her about the importance of utilizing a healthy lifestyle to also improve her body image, which was a contributor for her. She ended up pursuing reconstruction, and she was very pleased with the outcome and the lifestyle changes she had at her follow-up visits with myself in the breast center as well.
And so this is actually one of my patients. And so I saw her at the time of diagnosis. And I think what this case highlights to me is that you would never know that these issues were going to be her issues when you meet her. So she had this ovarian cancer. She did fine with it. She came in obviously emotionally distraught about her new breast cancer and wanting to know if she was going to die from it. But beyond that, you think as a practitioner, you can get a sense of like who's going to be a high needs survivor. And this wasn't that kind of a person. So I think to me, again, I think it just highlights that every patient has their own set of issues, and a lot of what she's struggling with are induced by our treatments. And she didn't even get chemo or radiation. So it's a reminder to me to not prejudge or think like, oh, that person's going to be fine, and then that person's going to need a ton of help. Because she, for all intents and purposes, was completely put together and, not somebody that you would guess had a long list of needs.
Absolutely. Thanks, Sarah.
Yeah.
Maura?
Oh, okay, I'll go next. So this was interesting because she was a recent Russian immigrant. So, we start talking about what were her customary foods. So you want to address, their cultural foods, and also to find out that she really wasn't in charge of the food at home. Her husband did all the food shopping and cooking. So then she didn't really have that much autonomy in terms of making changes. So that's something, we talked about. And also that she was recovering from this, big surgery, a deep flap reconstruction. It's huge. And so looking at kind of the meal composition that was typical of the Russian cuisine and realizing we needed to adjust kind of the macronutrient distribution to make it a little more protein sparing, with making sure she had adequate carbohydrate to allow enough protein to promote wound healing. And we were able to do that by adjusting the portion sizes on the plate rather than saying to her husband, I need to eat differently. It was like, well, let's work with what you are doing. So she could eat the same foods as her husband, but just alter the proportions on the plate. Then there was the issue of her weight, because we're going to be going into more weight management as the rest of this session. But she was, as we see with breast cancer patients, someone who gained weight during treatment. And it often comes as a surprise to women. They often think that's the silver lining of a breast cancer diagnosis, that they're finally going to lose that 20 pounds that they've been trying to and couldn't, and then they end up gaining weight. So she gained 13 pounds during treatment, and that was 6% weight gain. So, so when she presented to us, she was already at a BMI of 39. But as we were discussing, she didn't look it. She carried her weight well. Probably very good bone density. But in terms, and the reason I bring this up, because you see someone with a BMI of 39, and I also said to her at that time, this is not the time to lose weight. You're healing from surgery. Let's nourish your body. Let's make sure you're getting the nutrients that you need, and then we'll move to weight loss once you've healed. But for her, a weight loss goal would be 10% of her body weight, which would be 23 pounds, which would be a very successful weight loss. It still put her at a BMI of 34, which is good, but it just goes to show the limitations if you're just going by BMI. That's often a lot of bad messaging patients get, that their weight goals are based upon BMI. And you should weigh a BMI of 25. We hear this over and over again, and it does a disservice to patients. So for her, a BMI of 25, she would have had to lost over 80 pounds, which, as I always say, it ain't gonna happen. So why do that to somebody? Because you're just setting them up for failure. So for her, a successful weight loss, which gets the full medical benefit, would still have her at a BMI of 34. And I'll get more into that in the didactic. If anyone has any comments about that or questions, raise your hand or send something in the chat room. And before I pass it on to Scott.
I'm going to go ahead and unmute everyone one more time. If we get feedback, I'll mute again, but I think we should be okay. Again, if anyone has any questions, comments, thoughts, feel free to jump in. Okay, so I'm going to go ahead and mute everyone again. We'll turn it over to Scott to talk a little bit about his visit.
Okay, so as Jevin was talking, can you hear me? As Jevin was saying earlier, she was experiencing some joint pain because of the aromatase inhibitors, and actually more it's interesting that you just said that she was big bone and she was carrying her weight well, but obviously we know that that's one of the other side effects of the AIs is accelerated bone loss, and so it really is the double whammy that we need our patients who are on AIs to move. We want them preferably to be doing weight-bearing exercises, not just to help with the joint pains, but to help with prevent that bone loss as well. So for her, I had to counsel her on the importance of moving and really the consistency. It kind of goes along with what Maura was just talking about with, you work with what you've got, and telling our patients that you don't have to, You don't have to be perfect. You don't have to be training for an Ironman triathlon, but just to consistently do 15 minutes, 20 minutes, 30 minutes, a couple times a week, rather than saying, oh, I'll get all my walking in on the weekend. I'll go for an hour-long hike on a Saturday, but then not do anything the rest of the week. You're not going to get any weight loss benefits that way. Interestingly for her, even though she didn't have radiation after her treatments, she still has some limitations in her upper body range of motion and definitely some decreased strength. So ironically enough, I have actually just started seeing her for one-on-one physical therapy to address some of those range of motion issues and that upper body strength. And as part of our plan of care, I'm also going to be addressing the cardiovascular aspect of things as well, to kind of put the whole picture together to help her with her weight loss.
Thanks, Scott, and thanks everyone for sharing a little bit about her. Again, I'll stop briefly and ask if anyone has any questions or thoughts on this case. Anything that maybe you can relate to, having seen a survivor in your own clinic, and maybe some overlapping concerns. And feel free to chime in. Sorry about that. Feel free to chime in with any questions or anything like that. We also have the chat box open for anybody on the computer. Okay, how about I'll pose a question to everyone then. Any particular themes that you're seeing amongst the four of us having spoken about this case that you can say, okay, that's something that could be a common message, or any particular aspect of this case that would be interesting to hone in on from one of our perspectives, either from the medical standpoint, nutritional standpoint, exercise standpoint. Unfortunately, Angela, our social worker, is not here today. She couldn't be, unfortunately, but.
I mean, I love the theme of meeting patients where they are.
Yeah.
And working with what you've got. It's very patient-centered, and it's not something that we typically do, right? Because we follow a bunch of standards, and in order to meet this standard, you must do this and this and this. But the best patient-centered approach is to really kind of ask them what their goals are, right? And help them meet those goals in the framework of an evidence-based structure. So to me, that's the importance of what we're doing in survivorship.
Just had a question pop up in the chat room. When patients have multiple goals, how do you help them prioritize, and how often do you see them for a return visit? So I'll take the second half of that question first. We see our patients for 2 visits. We see them at their initial visit, and that's where, again, that first visit is a lot of listening to, and again, meeting them where they are and where they, really finding out what their needs are and really getting a chance to learn who this person is who's sitting in front of us. And then we'll all kind of chime in and kind of give them some recommendations that, we'll each give them something to kind of work on, some of those lifestyle changes that they could do at home. And then we'll typically see them for a follow-up visit, usually 2 months later. And that's, 2 to 3 months later, just to see how everything is going. It's a check-in. For more of, you look at, have they lost any weight since that last visit? I'll look at, is their strength any better? Is their fatigue any lower than last time? Jevin, if you've made recommendations as far as, did you follow up with getting that colonoscopy or that sort of thing? Did they make those appointments? Yeah. But honestly, we don't put a cap on it. We have had survivors come back for a third visit, sometimes 6 months later, sometimes a year later. We've had several survivors who we'll see, and then we don't see them for years later because their survivorship needs change as their life changes, depending on where they are in their own life stage. So the very long-winded answer to that is we see them for 2 visits, but there's really no cap on how many visits we see them for.
Yeah, thanks, Scott. And Jevin here again. To talk a little bit about addressing multiple concerns and hitting certain goals. I think it's about really, first of all, coming in with that intake that they fill out for us, what their two primary concerns are, and then talking with them about it during the visit. Yes, you know, we received your intake and these are your two primary concerns, but I always try to open up with, what are your concerns today? What do you want to talk with me about? And oftentimes, you know, it will match up with those two concerns if there's something that hasn't already been addressed with someone else from the team. But sometimes there'll be other things that maybe weren't highlighted or they forgot to check off on their you know, pre-screening paperwork before coming in for the visit. And so then it's a matter of, okay, assessing how much is this bothersome to the person? How big of a concern is it? And of course, if there's any urgency to it, and triaging that appropriately as well. And the way to help address, you know, actually meeting the goals for them is to help them break it down and say, okay, what are things that are feasible within their lifestyle? And again, as Tara alluded to before, meeting them where they're at.
And I would even say too, you know, and this goes back to, you know, what you guys are both been saying about meeting the patient where they are. We've had this happen more than once where, you know, a patient will make an appointment and Kiki send them their intake form. They fill out their intake form and they send it back, but their appointment may not be for, you know, for a couple weeks later. And since they filled out the intake form until the day that they actually show up, something else could have happened, like they lost their job or something like that. So their needs have changed just in the short time frame from when they fill out the intake form.
Yeah.
So again, it's where are they at that exact moment when they're sitting in front of us.
Well, the beauty of survivorship is it can be fluid. So I would say, you know, once or twice a year, there's a patient who walks through the door and we say, oh, like this person only can, you know, needs Angela right now. She needs some major, it's like he or she needs major psychosocial support, and the rest of it can kind of be scrapped. So, you know, there are some times where the pressing need is so overwhelming that the rest of us, the messaging doesn't really get through until you address the most pressing need. And so that doesn't happen that often, but when it does, we just, we go with it.
But I think another way we come at it is because it's a multidisciplinary team, that we can focus on our area and help the patient, you know, just focus on, let's say, nutrition with me, and it can kind of put aside those other issues and say, you know, that you need to discuss that with Scott. So it helps kind of help the patient focus on that particular concern. And I find that one of the great benefits of having a team is it helps me do a better nutrition session, because I know other people, I can redirect those other concerns to the other team members. It's a very efficient use of time, and it helps the patient kind of organize it too.
All right. Does anyone have any other thoughts? I still have everyone unmuted. Does anyone have any other thoughts on the case or any questions? Again, feel free to use the chat.
Hi, it's Holly from Oregon. I was just wondering, hi, and I have Abby, our dietitian, here as well.
Yeah,
Welcome, Abby.
Hi. And we were just wondering about the timing of the intake form for the survivorship. Is it when are you giving that? And is that just done before the first person who sees that person?
yeah,
And was that, yeah.
Go ahead.
And then I can't remember if the intake forms you guys had included with the original information, or if we've seen those yet, or if we could.
Yes, so I did upload all those to Box. I don't have them available right here with me. I can send out the link again if you haven't gotten it. It's as simple as clicking on it, and then you'll have access to the folders of all that information. But the intake is sent out before they come in for the visit. So at the time they're called for an appointment by a program coordinator, Kiki, she will let them know that she's going to send them an intake form either by mail or electronically through MyChart and our EMR. And they'll be able to fill that out and send it back prior to coming in for the visit. The time range can vary depending on when they have the visit scheduled.
we've, this has been a document that we've revised almost annually. But I would say in the past few years, we've really found a groove. And these, if you do nothing else with an intake, having the top 2 priorities specified by the patient, it's a specific tool that's been validated called My Cause, CAWS. But it's just a free text. What's your top 2 concerns and how much are they affecting your quality of life? I find this to be very rewarding because you see that the themes are very much aligned with what we're doing in clinic. And also the patients just coming up with it on their own. It's not at all like a checkbox. So, so they're really, you're hearing their voice. Yeah.
Okay, great question, Holly. Any other questions or thoughts on the case or general questions?
Hi, this is Abby with Holly.
Oh, hi, Abby.
Do you re-administer the intake tool at the second visit, or is it just at the initial scheduling for the first visit?
So great question. And we do not re-administer the intake for the second visit. But again, something that we focus on in our huddle before we see the survivors that day, we'll review our initial visit, readdress those top 2 concerns with the person we're seeing, and then ask what other concerns they have that day. The idea is also to see, have they met the goals that they were looking to meet from the first visit, and what further needs do they have off of that?
I just want to chime in. It's Angela, program coordinator. So we do send another intake if the patient hasn't been seen in quite some time. So we're talking about years, only because it may have changed for them. But usually if it's within a year or 2, we do not for the second visit.
Thanks. Okay, and thanks, Abby. Appreciate that. I hope that answered your question. Any other comments or questions before we move along here? We have time for maybe one more, if there was any. Okay, so I think we're gonna move along to the didactic presentation. I'm gonna share the screen with you so you can see, for those of you on the computer, you can see the.
Kevin, just as you're pulling that up, I'll answer this quickly.
Sure.
Question just came up about the distress thermometer, and so yes, the distress thermometer is filled out at each visit, and it's within that visit, it's filled out pre and post. So I guess technically there's 4 distress thermometers over 2 visits.
Another very helpful tool to help guide where we're going with the conversation. And we've shown, we've presented that our survivorship is an intervention for distress in and of itself, and we lower distress significantly, and that change is sustained over time. So we see lower results coming in for the second visit than we did at the first visit, which is very satisfying.
Yeah, absolutely. Okay, great questions, everyone. Thanks for all of that, and we're gonna jump into the presentation now. Okay. And for the presentation, I'll turn it over to Maura.
Thanks. Okay, so I know there are a lot of dietitians out there, but I know there are some non-dietitians out there. And so this is a public service announcement on behalf of dietitians, just so people know that there are advanced practice certifications within our profession, 2 of which are adult weight management and oncology nutrition. Now, I happen to have both, so I folded these principles into this presentation. So this is going to be a different approach to weight management. As the dietitians out there know, most of our patients get their formal nutrition education via the diet industry. Paleo, keto, clean 30, fill in the blank. It's full of conflicting concepts, misinformation to varying degrees. My apologies to the physicians in the room and out there, but unfortunately most healthcare providers get their nutrition information the same way. This makes the dietitian's job more difficult. But we have to recognize that the dieting industry is a $72 billion industry, and they're designed to fail. So my approach to weight management first is to undo dieters' mentality and to teach the concepts of a lifestyle intervention consisting of healthy eating, daily exercise, and mindful eating behaviors. I'll let that sink in for a moment. And the goal being that this is sustainable. This is what you do for life. The focus is on nourishing your body, moving your body, aligning your fueling with your activity, and looking at eating behaviors. How you eat is just as important as what you eat. There is no counting calories. There is no focus on the number on the bathroom scale, because clinically meaningful weight loss will naturally follow this approach. Okay, that was my big lead-in. So, all right, that's, I'm ready for any kind of blowback, but let's hear it. So feel free to do the chat room. Now, any discussion of weight management must be had in the context of the ongoing obesity epidemic. When we understand this epidemic from an evolutionary point of view, we then understand the power of this lifestyle approach. So let's put our bodies in the context of evolution as a species. Our modern time, honestly, just represents a mere 4 generations, a nanosecond in the tens of thousands of years of human evolution. So our bodies are designed for survival in an environment where food is scarce, and we had to physically work hard for every calorie and nutrient. Metabolically, we are designed for feast or famine. Mostly it's famine. But when that woolly mammoth came along, there was an occasional feast. Our bodies readily adapt to famine and starvation by becoming metabolically thrifty. Our bodies respond to feast by having unlimited storage of excess calories, which enable us to live off the fat of our body to get us through the next famine. So here's the bottom line. Our bodies are designed to gain weight easily in unlimited amounts and to lose weight very reluctantly in very limited amounts. All of this is for survival of our species in an environment that no longer exists. I'll let that sink in. Coming at it from a different direction, I'm sure, for a lot of you when you think about weight loss. But the thing is, let's fast forward to today. And what environment have we created for ourselves? Well, one with a drive-through window, with no physical effort required, to receive easily 3,000 calories full of fat, added sugars, and salt. We've also created a food industry that intentionally adds sugar, salt, and fat to our food supply. Why? Because it sells products by intentionally tapping into our innate preferences that help us survive when we had to forage for food. So sugar in nature signals the food is not poisonous. It's safe to eat. It's a comfort. Fat represents a concentrated source of calories, and salt keeps us hydrated. These are all needed eating strategies when food is scarce. So the bottom line is our bodies are mismatched for this modern environment we have created. It's no wonder that over 70% of American adults are overweight or obese. So now let's look at this effectiveness in cancer. This influence of overweight and obesity in cancer is so powerful that attaining a healthy weight is the first goal in the cancer prevention guidelines from the World Cancer Research Fund, American Institute for Cancer Research guidelines. Now, how do you like this first slide? This is, I wanted to take a look at mechanisms here. And I'm going to try to neatly summarize this busy slide to explain the role of obesity in cancer. I'll let the docs tell me how I did with this. But the excess adipose tissue, or the fat cells that are from overweight and obesity, are more than just storage of excess energy for the famine that we now realize is never coming. The adipose tissue is also an endocrine organ. So obesity causes chronic inflammation, and along with concurrent insulin resistance, creates a hormonal milieu. That's my shorthand way for describing that whole slide, that stimulates cell growth, angiogenesis, and tumor growth. These mechanisms also promote diabetes. and hence the interest in using metformin to prevent cancer, which I'll note later, but it has implications when I get to the lean study. So how did I do, Doc?
Excellent. That's exactly right.
Right.
Good job.
Thank you. All right, so I wanted to introduce the lean study, the lifestyle, exercise, and nutrition study, because in this study, we pulled together all these concepts and designed a lifestyle intervention for breast cancer survivors. And here's just the study design. It was a 2-arm randomized controlled trial of 200 overweight or obese breast cancer survivors who received instruction on lifestyle intervention over 6 months. What I love about this is in the design that the waitlist control women also received the lifestyle intervention after they waited 6 months. So everyone got the intervention. But I wanted to take a bit of a deep dive into how we designed the lifestyle intervention for the lean study. And it's based upon the diabetes prevention protocol, which was a landmark study that was a lifestyle intervention for the prevention of diabetes. This lifestyle intervention was pitted against metformin in the study for prevention of diabetes. The lifestyle intervention outperformed metformin. The lifestyle intervention reduced the incidence of diabetes by 27%, where the metformin reduced it by only 18. The study was halted, and all the participants received the lifestyle intervention. Go lifestyle intervention, right? I mean, this is great. So this is a powerhouse landmark study. So when we think back to that mechanism slide where the similar mechanisms of obesity in promoting cancer and diabetes, you can see the powerful role that lifestyle intervention has in the prevention of cancer and reduced risk of recurrence. Now, as dietitians, we know lifestyle intervention is well established in the diabetes world, and it's well established in the cardiovascular world. We now need to bring it into standard of practice in the cancer world. If you want the building blocks of a lifestyle intervention, go to the DPP website. It's all there for you. It's free. It's beautiful. So we use that as a foundation. And then at the time, we updated it with the 2010 dietary guidelines, and we adapted it to the special concerns of the breast cancer population. Basically, it was a predominantly plant-based diet, 150 minutes a week of exercise of choice, mostly walking, and 10,000 steps a day. So that's kind of the template. Now, the counseling sessions were 11 sessions over 6 months. And I have to admit, true lifestyle intervention is labor intensive. It's not a one-shot deal. It's multiple deals. It takes 3 months to learn new skills and 3 months to practice them to establish it as a new lifestyle, hence the 6-month template. Now, the counseling techniques are important. And again, I'm going to get on my RD bandwagon, but this cannot be done by just anybody. This can't be done by quote unquote health coaches. They don't have the training that RDs do. So we have the skills, the counseling skills to actually make this lifestyle intervention meaningful and sustainable. So look at the results. An average of 6%, just 6% weight loss produced a 30% reduction in C-reactive protein, which is a marker of inflammation, and also a reduction of circulating insulin and leptin. The takeaway story here is it doesn't take much weight loss to get the medical benefit of the weight loss. And I can't say that enough. So as little, and as we go to the next slide, weight loss goals, as little as 2% gets a clinically meaningful weight loss with medical benefits. Unfortunately, when we go back to our Stone Age body, our body really is only willing to give up 10%. And that's why when you get to things like bariatric surgery, that kind of breaks through that 10%, but not much farther. But that is the metabolic barrier. But often job one in weight management is preventing further weight gain. Okay. So that was the original lean study. Now we're going to fast forward to today, and Dr. Sam's a PI on this, which is our 4th iteration of the lean study. And we moved the lifestyle intervention further upstream to the time of diagnosis. And our goal is prevention of the weight gain that we typically saw during breast cancer treatment. But also, we're providing aggressive management of nutrition impact symptoms of active treatment. And the primary aim is to improve chemotherapy completion rates. Our hope is that with the results of this study, that we will allow lifestyle intervention to become part of the standard of care of every cancer patient. So it's a big goal. We're shooting for it. We're going to do it. Right, Tara?
Absolutely.
We're halfway there. So if you allow me, I just wanted to go into some of the counseling techniques that we use for lifestyle intervention. And this is my quote of my philosophy, which is that you just don't tell the patient what foods to eat. You give them the skills so that they can make a decision for themselves as to what's a healthy food. I'm just putting this up here as one of my favorite teaching tools from the American Institute of Cancer Research. It depicts visually what a predominantly plant-based diet looks like. I like to teach food in terms of visuals, because that's how people eat. If you get stuck and you only have one shot, this quote does the job. Eat food, not too much, mostly plants. Michael Pollan also has another great set of quotes. If it came from a plant, eat it. If it was made in a plant, don't. And here we are, we land on my most effective teaching tool, which I got out of Kids Catalog, which is just capturing all the colors of the rainbow as much as you can every day. Now, the science behind that is that the compounds in the plant foods that create the color are these hundreds of phytonutrients. This is just a handful of them. But these are the compounds that actually reduce inflammation in the body. So the key is the color in the eating. And another term for this is the anti-inflammatory diet. Now we also come at it with consumer skills, because you want the person to be able to make the decision on their own. We're doing a time check here. Okay. Oh, thank you. Okay. As many of the dietitians know out there, the nutrition facts labels have recently been revised, and they actually broke out the line for added sugars. This was a phenomenal improvement in the nutrition facts label, and they'll be completely phased in by January 2021. Again, a great teaching tool when you're trying to help people decrease their added sugars. There are a lot of aha moments when people go home and start looking through their pantry and see the added sugars. And we say you can have 30 grams a day. You just choose where you have it. And it's a great way to reduce added sugars. Now, one of the legs of the lifestyle intervention is the eating behaviors. And we talk about mindful eating. And I would say, to sum it up, is in obesity, what I see, there's a disconnect between the person's connection to their hunger and fullness cues. Now, I think that's hormonally driven, and we try to retrain the body to reconnect to those hunger and fullness cues by establishing regular meal times, regular snack times, deliberately eating more slowly, and the big one, intentionally stop eating before one becomes full. That's a great mindful practice, and people will say when they've established that, they know they've got this for life. And that's when the weight management happens. So how you eat is just as important as what you eat. Okay, so that ends my portion of the didactic. We'll take a pause, and any comments? Remember, no counting.
Healthier for listening to you speak, Laura. Amazing.
I'm going to pass this over to Scott, and Jevin and Angela's not here. I'll briefly cover it's the mindful eating practices. But I just want to also say at the end, I've come up with a 5-point message for the whole team, oncology team, in terms of nutrition and exercise. So I want you to really think about what you would add to those messages or comments, because I want to really hear what you think about it. But this is my pet project for the for Smilo, that will have a unified nutrition and exercise message given by all caregivers. So think about that, and now I'll hand it over to Scott.
So again, I think you guys might have seen this slide already. I've been talking about this a lot, these new exercise recommendations that were put forth by the American College of Sports Medicine back in October, talking about how we can really hone in our exercise recommendations really specifically to some of the specific symptoms that we see in cancer survivors, like fatigue and depression and anxiety. And really, first and foremost, it starts with aerobic exercise. That's really kind of your best bang for your buck as far as weight management is concerned. People will ask me, well, I've only got 30 minutes a day to exercise, so what should I do? And so I'll say, consistently, doing some sort of cardiovascular exercise engages the entire body, engages the heart, and engages the lungs, and includes your circulation. And so that's probably your best bang for your buck. You do want to try to do some strength training on your own, but strength training can be as simple as just doing some push-ups and planks at home. You don't have to necessarily join a gym to be able to do those types of things. But again, like Maura is talking about with lifestyle changes with eating, the same idea applies as far as the exercise. To come up with a way to systematically infuse exercise into your daily routine so that it's consistent. Again, working out once a week, you're not going to see the health benefits as opposed if you're exercising 5 or 6 times a week. Those of us in the physical therapy world will actually use this FIT acronym to kind of help us as far as defining, the frequency of exercise. So again, trying to get out to exercise, 4, 5, 6 times a week. The intensity is something that we can play with a little bit. People will ask, well, does gardening count as exercise? Or do laundry for exercise? And that's all well and good. But when we talk about intensity, we're talking about raising the heart rate, getting to the point where you can still have a conversation while you're exercising, but you can't necessarily sing. And if you have wearable technology that can monitor your heart rate, you want to get somewhere between 65, 70, 75% of your maximum predicted heart rate as far as the intensity of the exercise. Anything below that, you're really not achieving a therapeutic benefit of exercise. Again, the time, ideally, you're trying to exercise, for a good chunk of time, 30 minutes at a time. Some people will say, does 10 minutes 3 times a day count? And for some people, yes, something is better than nothing. But I'll try to have those have people who say that try to take those 3 10-minute segments and try to combine them into 2 15-minute segments until they can eventually put it together as 1 30-minute session. Probably the most important part of this FIT acronym is the type. We're not going to get somebody to exercise if we force on them the kind of exercise that we want them to do. Ultimately, it's got to come down to something that they want to do. Again, a woman who's on an aromatase inhibitor, you're going to try to get them to do more weight-bearing exercise, but realize that there's so many different options when it comes to cardiovascular exercise, and even dependent upon where you live in the country, what time of year it is. If you live in the north or the northeast in the wintertime, maybe you want to try snowshoeing or cross-country skiing or something like that to kind of mix it up. And again, just talking about the different forms of exercise, aerobic, the heart rate's a little bit lower versus the high intensity interval training. Your heart rate intensity is a little bit higher.
Okay, Angela unfortunately isn't here, and So I think in terms of time, I'm gonna kind of skip through her slides and get right to Jevon's. We'll have Angela cover hers next time. And here's Jevon.
And they're available to the community for reading.
Yes,
So
yeah.
those points can be reviewed.
yes.
Exactly. Yep, everything's up on Box. All right, so when I am discussing nutrition and exercise with anybody I see, it's important to make sure you're able to broach the subject. It should be a routine. These should be routine topics to address during the visit. And it's important to create an inviting environment to talk about it. I'll often start the visit by asking, or not start the visit, but introduce the topic by asking, so tell me a little bit about your day-to-day eating habits, or what your nutrition has looked like lately. Tell me about the amount of exercise you're getting typically during the week, or tell me what physical activity you've been doing. It's important to always make sure you're cognizant of, again, where the patient is at, and to never blame them for not doing something that maybe you feel they either should be doing or going in line with the recommendations and the guidelines. Oftentimes they come in if someone's overweight, if someone has obesity, they know that already. It's not something that you need to reiterate to them. And so it's important, again, as we mentioned before, to meet them where they're at and work with the starting point they're coming from to build from there. And you don't want to ever assume that this topic's being addressed by someone else. Actually, less than 40% of primary care providers are addressing diet and exercise. And as of 2010, 32.4% who had seen any physician received any counseling on this. So it's important to be discussing this with your patients. Never be afraid to bring up this topic. And it's important, as I mentioned, to listen to your patients. And I always encourage motivational interviewing, and I utilize this when talking with people, whether it's listening to them and hearing their needs that they have, or encouraging them and crediting them for changes they've made to make improvements. This will help to empower the person and lead to actual change. And I just wanted to briefly talk about some of the benefits from, again, nutrition and exercise intervention. As Maura mentioned before, I won't go through all of this, but it can help reduce the risk of cancer recurrence and occurrence through the mechanisms Maura mentioned before. As a matter of fact, to highlight some of the studies that have been out there and done, the Women's Intervention Nutrition Study showed 54% improvement in overall survival for ER/PR negative breast cancers on the intervention arm, and that focused around, again, the importance of nutritional counseling on a low-fat diet. Additionally, there have been a number of other studies out there and meta-analyses showing benefits in other cancers as well, including colorectal, ovarian, brain, prostate, and non-small cell lung cancers, just to name a few. And so these studies are out there that show that it does directly impact reducing risk of cancer. Additionally, there are a number of overall health benefits that can help with cardiovascular health, bone health, diabetes, diabetic management, lowering cholesterol, improving mood, helping with oral disease, and helping with overall gastrointestinal health as well.
Okay, so here we're going to wrap it up here. Not all of us are blessed to have Jevon addressing nutrition and exercise, or Dr. Sands or Ashley. But I would like to be able to craft a team message that is given to the patient throughout their treatments, from the surgeons, from the oncologists, from the radiologists, from nursing, that address nutrition and exercise and ultimately weight management. The first message is to say to the patient, nutrition and exercise, this is your contribution to your care. Put it that way. It's very empowering to the patient. This is your piece. You tend to this piece, everything else works better. So they become part of the team, they have more agency in their care. The second message, My favorite, add some color to every meal. It's that simple. Next, movement is medicine. This is Scott's message. The importance of continuing to move. Number 4, none of this has to be perfect. It's the 80-20 rule. 80% of the time gets the job done. 20% is at your discretion. And anyone who knows me knows my 20% includes that jelly donut. And team message 5 is that this is an everyday thing, but every day is a new opportunity to move more and eat smarter. Very simple messages, but it keeps driving home the point to the patient that this is important, and it nudges them to make incremental changes to improving their lifestyle. And that's it.
All right. Well, thank you everyone for taking the time to listen to all of that. I know we're up against it here. We have about 3 minutes left before it hits 3 p.m. Eastern time here. Want to ask if anybody has questions. I'm going to unmute everyone and just mute a few people so that we're having feedback. Sorry about that. If you have any questions in the chat or discussion, feel free to let us know. Any comments?
Hey, it's Amanda here. Can you guys hear me?
Yes,
Yeah,
Amanda.
hi.
Hi, well, thank you for that presentation. I mean, I had emailed Maura separately, so she knows that I have many opinions, but I fully believe in the power of the nudge. So I really appreciate the consistency of messaging that you and your team have. And I'm here at NYU Cancer Center in Manhattan with many satellite locations. So we have messaging coming from our team, oncologists, advanced practice practitioners all over, that range from your food matters, you need to eat vegan and organic, to your food doesn't matter, you can eat whatever you want. So my question to you is, how do you try to corral messaging for purposes of consistency and accuracy?
Great question.
It's a great
I
question.
think that's the challenge. I think we've yet to do it. We do our best in terms of, I think our outreach is with the lean study. That's where we kind of get out and address different teams, but it's something that I think needs to be adopted as a organization, that this is important, and that everyone agrees on what that messaging is. Because as you said, Amanda, it creates a lot of confusion to the patient. Yeah, eat whatever you can versus, oh, you got to be vegan.
Yeah, and Amanda, I love this question because, all of us human beings become kind of like armchair experts as we discover our own, healthy lifestyles that we adopt, right? So within oncology, people are on all different spectrums. We have triathletes who, don't eat anything processed and only whole foods, and we have oncologists in particular who don't practice any of the healthy diet or exercise, and in fact probably have some poor coping mechanisms with their stress levels, right? So just this morning I was at a care center discussing the Survivorship clinic, and there were millions of opinions as to dietary counseling. I think what's nice is that there is a wave of people becoming aware that this is something we need to take seriously, that our patients are doing it with or without us, and they have very fixed ideas, and that as a medical society community, we need to adopt evidence-based counseling messages. And I think the providers are hungry for, and the pun intended, I guess, hungry for evidence-based messages. And so sometimes people scoff at the rainbow because they're like, that's so simple. But the truth is, when you look at your plate, like I have, and with my kids, and realize it's all white, now I start to feel a little panicky. Like, okay, what do we have green in the fridge? Like, quick, let's put something red on the plate. So again, a long-winded answer to say that we're getting there. And the first idea is to just talk about it. Yes.
And just a couple off of what Tara was saying, that's exactly one of the barriers, is that there aren't a lot of guidelines out there. There isn't a lot of training out there, and that lack thereof is what causes the difficulty for providers at addressing this topic in the first place. But hopefully you've heard from all of us and know now it is an important topic to address regardless of that. And there are some simple strategies for bringing it up with your patients. Great question there. Really appreciate that, Amanda.
Well, thank you very much, everyone, for your input.
Yeah, absolutely. Anybody else have any other questions, thoughts, concerns? We have a chat window of 2. It looks like we're a few minutes over. Time for maybe one more. Okay, not hearing anything. Crickets, just a quick reminder that again, this session will be posted up on Box. I'm working on getting the actual session recordings up there. The post-session survey will go out in the email following this session. Please ask you to fill that out. And if there are any questions left on the table that maybe we couldn't get to today, you thought of after, you're like, darn, why didn't I think of it then? Feel free to put it into the post-session survey too, and let us know, and we'd be happy to address it. I want to encourage all of you especially to do this time around, because our last session will be coming up in 2 weeks on December 18th. And we're kind of getting an idea from, we're hoping to get an idea from everyone of what topics maybe you want to address in that, and keeping it open-ended, more of an open forum for any questions or additional concerns you have based off of previous sessions. Feel free to let us know. You can shoot an email as well if that's easier than filling out the survey, but that's a good way to do it. All right, so thank you everyone. Hope you all again had a happy Thanksgiving, and we'll see you before the next holiday coming up on December 18th.
Yeah.
Bye everyone.
Bye, guys.
Bye.